So the RESONANCE study is a confirmatory, and it's actually the first randomized phase 3 study to be presented with Ibrutinib, comparing it to a standard comparator in relapsed and refractory and hard to treat CLL patients. The study, the study included 391 patients. It randomized 1-to-1 of Ibrutinib, in the first-in-class oral BTK inhibitor against ofatumumab, a standard therapy used in CLL. The results were really striking in that when you look at the primary endpoint, progression-free survival, there was a dramatic difference. Early on, the 6-month progression-free survival on Ibrutinib was 88% versus 65% for ofatumumab. The overall survival, despite a crossover being allowed early in the therapy, was still observed with Ibrutinib. And the estimated survival at 1 year was 90% with Ibrutinib versus 81% with ofatumumab. When you look at the survival curves, at 9 months in the study where the crossover was allowed, the comparator ofatumumab survival plateaus. So that really shows how much Ibrutinib is impacting both the response, the progression-free survival, and the overall survival of CLL. The results are important because they confirm the efficacy of Ibrutinib as compared to a standard comparator for the very first time. And for me, as a doctor that takes care of CLL, it says that with the exception of the very, very rare relapsed and refractory CLL patient, Ibrutinib should be something that we're considering for them. These data clearly support the use of Ibrutinib as a second-line therapy. For clinical trials right now are ongoing, looking at Ibrutinib in first-line therapy, and if the results look as good in that setting as compared to what they look in relapse, what we hope is that in the future we'll be treating CLL with a non-chemotherapy-based treatment versus chemoimmunotherapy that we're using now. Generally, CLL is treated when patients are symptomatic, and so that's the criteria we would use. There are certain markers that predict that our traditional therapies won't work, and what's really exciting about Ibrutinib, one of those is the deletion 17p, and Ibrutinib works better, as well against that group in terms of response, and producing durable responses. So Bruton's tyrosine kinase is part of the B-cell receptor signaling, and what it does is it essentially strangles the cell from inside and prevents it from getting nutrition from the microenvironment on the outside of it. And so it causes the CLL cells to both stop dividing or proliferating, and it causes them to slowly die. And Ibrutinib targets BTK very effectively, so you have a good target, a good drug, and together you have something that's transformative for CLL patients. To the busy cancer doctor, we have a new transformative patient-friendly drug for CLL, that in the great majority of our relapse patients we should be considering over our other older options for this disease. We should be considering Ibrutinib in all of our relapse and refractory CLL patients.